Margaret is 74 years old. She lives alone in the house her husband built in 1978. She makes her own coffee. She drives to her daughter's place on Sundays. And until last spring, she would have told you she was sharper than most people her age. Then her mornings started disappearing. It began small. A coffee mug she had put down somewhere and could not find. A name on the tip of her tongue that would not come. The feeling, around 10 o'clock most mornings, that she was moving through her own kitchen as if it were someone else's house. By August, she had fallen twice. Once in the bathroom, once on the stairs. Her daughter took her to her primary care doctor, who ordered a brain MRI. It was normal. He referred her to a neurologist who ordered a memory panel. Mild cognitive impairment, possibly early dementia, the report said. He recommended she schedule a follow-up in 6 months. Margaret was prescribed nothing. She was sent home with a folder of materials about dementia. What every doctor she saw missed was sitting on her nightstand. Her balance problem was not her balance. Her vestibular exam was normal. Her memory problem was not dementia. The MRI was clean. The neuropsychological testing showed a very specific pattern. She struggled with forming new memories, but her older memories were intact. That is not how Alzheimer's typically begins. Her morning confusion was not a stroke. The cardiology workup was normal. 3 specialists, 6 appointments, $12,000 in tests, and not one of them asked her the simplest question in geriatric medicine. What do you take to fall asleep at night? My name is Dr. Carter. I have spent the last 20 years caring for older adults, and if there is one conversation I wish every patient walked in ready to have, it is this one. What Margaret's doctors missed is one of the most common mistakes in geriatric medicine today. And it is the reason the medication on Margaret's nightstand sits at the very top of the American Geriatrics Society's list of pills that should be avoided in adults over 65. Not minimized, not used carefully, avoided in all older adults, without exception. Today, I am going to tell you what was on her nightstand. I am going to show you the research her doctors should have known. I am going to walk you through how Margaret's daughter eventually figured it out and the one sentence she said to her mother's pharmacist that changed everything. And if you, or someone you love, takes anything to help with sleep or anxiety, even just sometimes, this is one of the most important 12 minutes you will spend this week. The medication on Margaret's nightstand was a benzodiazepine. If you do not recognize that word, you almost certainly recognize the brand names. Xanax, Ativan, Valium, Klonopin, Restorial, Haltion. They are a class of medications that have been prescribed for anxiety and sleep for more than 60 years. Margaret had been taking one of them every night for 19 years. It started after her husband died. Her doctor at the time prescribed it for sleep, said to use it as needed. As needed slowly became every night. Every night slowly became something her body could no longer fall asleep without. 19 years on the same pill. 19 years no one reviewed. In 2023, the American Geriatrics Society updated its Beers criteria, the gold standard list of medications considered potentially inappropriate for older adults. And for benzodiazepines, the recommendation was unusually direct. Avoid in all older adults. Not avoid if frail. Not avoid if there is a fall history. Not avoid in high doses. Just avoid. The reason is that benzodiazepines do something specific to the aging brain that they do not do to a younger brain. In your 30s or 40s, a benzodiazepine works on a system in your brain called the GABA system. It calms electrical activity. It helps you fall asleep. And by morning, most of it is metabolized out of your bloodstream. In your 70s, 2 things change. Your liver and kidneys clear the medication far more slowly. A pill that should be gone by morning is still circulating at lunchtime, still circulating in the afternoon. Some long-acting benzodiazepines in older adults take days to fully clear, and your aging brain is far more sensitive to what is left. The same dose that produced gentle sedation at 50 produces something closer to a low-grade fog at 75. That fog is the mechanism behind one of the recognized short-term effects of benzodiazepines, what neurologists call anterograde amnesia, the impairment of new memory formation. You remember everything from before. You cannot form new memories of what you just did. You blamed it on aging. Margaret blamed it on aging. It was not aging. It was her pill. Margaret is not unusual. She is one of millions. According to research published in the Journal of the American Geriatrics Society, roughly 1 in 10 Medicare beneficiaries is currently prescribed a benzodiazepine. Among older adults with cognitive concerns, the number is higher. A 2026 analysis, drawing on Medicare data from 2013 through 2021, found that 1 in 4 Medicare recipients with dementia is currently prescribed a potentially inappropriate central nervous system medication, most often a benzodiazepine. And here is the part that should stop you. Among older adults who take a benzodiazepine chronically, between 50 and 80% experience adverse effects. 50 to 80%. The effects do not always look like a medication side effect. They look like aging, slower thinking, word-finding problems, new trouble sleeping through the night, daytime drowsiness, unsteadiness on the stairs, a general sense that the sharpness is gone. Most patients, like Margaret, blame all of it on their age. Most doctors, when seeing those symptoms in a 75-year-old, look for dementia, anxiety, depression, anything except the pill that has been on the prescription list for 15 years. The pill stopped being reviewed years ago. It was just refilled. Margaret's daughter is a nurse, not a geriatric nurse, not a pharmacist. A pediatric nurse who happened to remember something from a continuing education seminar. She drove her mother to the local pharmacy on a Tuesday morning and asked for a brown bag medication review. That is a service almost every American pharmacy offers, free of charge, that almost nobody knows about. You bring every prescription you take, every over-the-counter, every supplement, in a brown bag. The pharmacist sits with you for 20 minutes and reviews the list. Margaret's pharmacist read down the list, stopped on the benzodiazepine, and asked one question. How long have you been taking this? When Margaret said 19 years, the pharmacist looked at the daughter and said gently, "This medication is on a list called the Beers criteria. It is the medication geriatricians most often want reviewed. May I call your mother's doctor about a slow taper?" 3 months later, Margaret had stopped falling. 6 months later, her morning fog had cleared. A year later, the neurologist she had seen the previous summer reviewed her records and quietly removed the words mild cognitive impairment from her chart. She did not have early dementia. She had 19 years of benzodiazepine. So here is what to do. And this is the most important 60 seconds of this video. You do not stop a benzodiazepine. Not from this video. Not on your own. Not abruptly. Sudden discontinuation of benzodiazepines can cause serious withdrawal symptoms, including seizures. These medications require a slow, supervised taper that often takes weeks or months. But you can start the conversation today. The one sentence to take to your doctor or your pharmacist is this: I have been taking this medication for years. Given my age, can we review whether it is still the right one for me? That sentence works for almost any long-term prescription. But it works especially well for benzodiazepines because the answer the current evidence supports for almost every older adult is the same. Slow taper, supported, over time. A 2025 systematic review published in the Journal of the American Geriatrics Society found something remarkable. Written patient education alone, with no fancy intervention, was effective at supporting benzodiazepine deprescribing in older adults. The single biggest barrier was not the medication. It was not the withdrawal. It was that nobody had ever told the patient the conversation was possible. Bring 3 things to that conversation. Bring a written log of how long you have been taking it. Bring a list of every fall, every memory complaint, every foggy morning in the past year. And bring a willingness to taper slowly, over months if needed, with your doctor or pharmacist guiding you. The brown bag review, the pharmacist's question, the one sentence. That is exactly the path Margaret's daughter walked. I want to be direct with you, the same way I would be with a patient sitting in my office. For a small number of older adults, a benzodiazepine remains the right medication. For severe panic disorder, for certain seizure conditions, for end-of-life care. The Beers criteria recommendation says avoid, but it allows for individualized exceptions when the clinical judgment is sound. This is not a story about whether your prescription is wrong. It is a story about whether anyone has reviewed it in the last 5 years. The most dangerous thing in geriatric medicine is not medication. It is medication that has been refilled again and again without anyone asking whether it is still needed. Here is what we covered. Margaret was misdiagnosed 3 times. Mild cognitive impairment, balance problem, possible stroke. None of those were what was happening. What was happening was a benzodiazepine that had been on her nightstand for 19 years. The 2023 Beers criteria recommend avoiding benzodiazepines in all older adults without exception because of the documented risks of cognitive impairment, falls, fractures, and delirium. The path forward is a slow, supervised taper. Never stop on your own. Withdrawal can be dangerous. And the conversation starts with one sentence. I have been taking this medication for years. Given my age, can we review whether it is still the right one for me? But here is what I want to leave you with. Margaret's story is common. It is not the most surprising one I have come across in 20 years of practice. In the next video, I want to tell you about a man named Robert. Robert was not on a sleeping pill. He was not on a benzodiazepine. The medication that was quietly causing his 3 falls, his afternoon confusion, and the urinary problem he assumed was just a normal part of aging was not even on his prescription list. It was on his over-the-counter list. A pill millions of older adults take every night for a problem most of them have never told their doctor about. A pill on the Beers criteria for entirely different reasons than a benzodiazepine. And one that does something to the aging brain almost no one talks about. Subscribe so you do not miss it. And if Margaret's story sounded familiar, if you know someone whose nightstand has had the same pill on it for years, send this to them. Or to their daughter. Or to their son. The conversation has to start somewhere. It might as well start with someone who loves them. I will see you in the next one.